traditional, unceded, unsurrendered territory of the Anishinaabe Algonquin people. We thank all the generations of Anishinaabe Algonquin people for taking beautiful care of this land, and we recognize their historic connections to this land. We also value the contributions of other First Nation, Métis, and Inuit people who have and continue to shape and strengthen our community. So thank you. My name is Claude Brûlé. I am the president of College. And it's a distinct pleasure to give you a very warm welcome on this chilly morning here at Algonquin College in our beautiful Mewapin room. For those of you who are joining us online, I hope that you're staying warm at home as well. We are pleased to offer this event this morning in a hybrid speaker series in person. Last time was almost 3 years ago. Back across the country pretty well. So together. We used to be familiar with so now going at the same time. Are here bring us on Zoom before we get you can just click on the CC icon in the Zoom bar below. And second, if you have a question, and then we will respond if time allows. We also want to take the opportunity to share the hashtags for today. I want to encourage all of us to keep that conversation going on social media, and so we have hashtags ACHLE and hashtag ONHealth. So that's ONHEALTH. Thank you very much for keeping that conversation going on social media. This event continues to be the place to share ideas, to spark conversations, and discuss matters of relevance to the future of health and wellness across our community. And before I go further, I'd like to acknowledge the presence of some of our community stakeholders who have joined us. So first, let's start with those who are joining us remotely via Zoom. We have Lucille Collard, MPP for Ottawa-Vanier. We have Marty Carr, City Councillor for Ward 18, Alta Vista. And we have also a couple of our Board of Governor members who are joining us via Zoom. Our Vice Chair, James McCracken, and Tony Pollard from representing our Pembroke campus area. Joining us in person this morning, we have Chandra Pasma, our MPP for Ottawa West Nepean, Lane Johnson, College Ward Councillor, and Catherine Kitts, Councillor for Orleans South Mammon. We also have our distinguished board chair, Dr. Gail Beck, who's here this morning. Thank you, Dr. Beck, for joining us, as well as another Board of Governor member, Stephen Tudor. Welcome. So thank you all for joining us this morning and participating in our Future of Health and Wellness speaker series. And a special thanks to Dr. Hedges and the Ottawa Public Health for partnering on this event. It's a great partner to have. We've had many conversations. All of them, by the way, are online. We record all of these sessions, and they're there for your future viewing if you're so interested. We started these conversations in 2016, and we've covered everything from neonatal care all the way to palliative and everything in between. So there's a host of great topics to go and peruse. So let's get started. We're honored this morning to have a panel who will be joining us both in person and remotely. And I'll start with the introduction of Dr. Vera Hedges. She was appointed as Medical Officer of Health for Public Health, OPH, as affectionately known, in April 2018, having served as Deputy of the Minister of Health from 2014 to 2017.
Deputy Medical Officer of Health. That other Deputy Minister role
right.
is a big one there.
That's a bigger one. Thank you for that correction. So, yeah, Yes. Prior to joining OPH in 2009, Dr. Etches served as an Associate Medical Officer of Health, Acting Medical Officer of Health, and Director of Clinical Services at the Sudbury and District Health Unit, after completing her specialty training in public health and preventive medicine in 2005. Dr. Etches is also an adjunct professor at the University of Ottawa, where she continues to supervise medical residents in public health and preventive medicine and family medicine. Welcome. We also have Dr. Lawrence Loh, many of whom you probably have seen him on TV from time to time, different interviews related to COVID-19. He's the Executive Director and CEO of the College of Family Physicians of Canada. Dr. Loh became the Executive Director in September 2022. He began this role following more than a decade of senior medical leadership positions in the public sector, during which he served all three levels of government in skipping the page here, two provinces, including Public Health Agency of Canada and the Fraser Health Authority in British Columbia. While working at the Public Health Ontario, he was seconded as the Senior Medical Consultant to the Ministry of Health in the Office of the Chief Medical Officer of Health. Dr. Loh is also an adjunct professor at the Dalla Lana School of Public Health at the University of Toronto and a clinical lecturer at the Department of Family and Community Medicine at Queen's University in Kingston. Welcome, Dr. Loh. And finally, Dr. Gaynor Watson-Creed. She's the Associate Dean, Faculty of Medicine at Dalhousie University. She is a Royal College Certified Public Health and Preventative Medicine physician with over 17 years experience, having served as a former Medical Officer of Health for the Halifax area, and then Deputy Chief Medical Officer of Health for Nova Scotia. Dr. Creed sits as the chair or has been a member of several population health councils and boards nationally, including Public Health and Preventative Medicine Examination Board for the Royal College of Physicians and Surgeons of Canada, and the Advisory Council to the National Collaborating Center for Determinants of Health. So quite an esteemed panel here this morning to talk about public health policy, governance, and the future of public health. So we have a great series of questions, and of course we will welcome your questions as well in the Q&A. This session will provide thought leadership to the Algonquin College community, key community stakeholders and partners, as well as newly elected city official councillors, Board of Health members, and community partners about emerging and current topics. So let's get started. So to begin with, what we want to hear from our panelists and to give our audience a little bit of an overview of public health functions and scope. Is what we've seen during the pandemic. Everybody had their finger in the pie, from the federal, of course, the province, municipalities, all trying to do their best to coordinate what was a national, international crisis. We've learned a lot of lessons during the pandemic about the role that the municipality can play in this function to lead to better population health. So really what we're interested to understand is that overview of public health and what lessons learned we've gathered from the pandemic that can help inform these functions, certainly at the municipal role. Maybe here I'll start with you.
Well, thank you. Bonjour, Quay. Good morning. It's really lovely to be here, and I'm very thankful for the others who I will give more time to hear from others. But I would like to start by saying what the role of public health systems are in terms of how we view it. We need to improve the health of the population, protect the health of the population with attention to populations that have greater barriers to health. That idea of equity and paying attention to improving health for all is part of our function. And how we do that, we tend to think of three main ways. One is to begin with make the diagnosis, right? So measure population health. Think about what's the strength of the community, what's promoting health, what are the risk factors to health. And we do that again, we need to delve deeper into understanding differences across populations. And so I think linking this back to your question about how does the municipality play a role, I think this was something where we saw in the COVID pandemic response, as we in a public health system started to look at who was being most affected, we understood this was looking different by your postal code. And so municipalities, again, right there on the ground, knowing the different neighborhoods, were able to use that information to be alongside us and support with better access to social services, making connections on the human needs front alongside healthcare. So I know many today are here because of their connection to the healthcare system. So um, this is going to endure, this idea that we work together, social services, health services in the neighborhoods by postal code, guided by that data about where the needs are. The second thing we do as a function of public health is we use our tools for health promotion, health protection. So some of these tools, we've heard a lot about vaccination to protect the population, but some of them are about policy change. And again, I think this is where some of the work of municipalities comes in, and probably my colleagues will speak more. But we think about some of the real changes that have been made that have had a huge impact on the health of the population started with municipal action. For example, around addressing the risk factor of smoking with local bylaws. And in the pandemic, thinking about, again, what are the municipal options to increase options for housing and shelter and spread people out so that there's more, protection against transmission, and thinking about that in the long term. We know some of these elements and decisions at the municipal level make a difference for health. The third thing that we focus on as a function of public health is emergency preparedness and response. And again, I don't think that needs too much explanation in terms of how the municipality helped us during the pandemic, but access to the facilities that we needed, extra capacity from the city staff, paramedics, they all played a role in getting as much vaccination done as quickly as we could. And I think we think about the other emergencies we're facing. And I know it's hard to think about things getting too warm on a day like today, but of course, when we think about some of the ongoing pressures for emergency response and what we need to do to be prepared and try to mitigate that, municipalities have a role in climate change as well. And so we can expand on any of these things. Probably I'd like to pass it over to my colleagues. Yeah.
Thank you very much, Dr. So maybe if I can go to Dr. Watson-Creed next on that question.
Yeah, sure. Happy to be here this morning, and it sounds like it is as cold in your region as it is in my region of Turtle Island. So I'm coming to you from Mi'kma'ki, just outside of the Shipuktuk area, which is the area known as Halifax. I want to pick up on where Dr. Etches started, and thank you for that description, Vera, because I think it's really helpful. And I am going to do a little bit of a pardon me, but public health is in my bones, and teaching public health is now part of that DNA as I take on this role at Dalhousie University. Because I think it's important for the audience to recognize the very unique function that public health plays in our broader Canadian publicly funded healthcare system. So when I talk about public health, what I often say to people is, at the end of the day, and I trained both as a public health physician and a family physician, similar to Dr. Lowe and Dr. Etches. And so in my family practice days, I would always say I was always interested in anything that any individual brought in the door on any given day. And so you go through your list of 30 patients in a day, and you may have gone from removing somebody's sutures to a well baby visit to giving an immunization to a health counseling code. And at the end of that, hopefully you've understood what's happening and you're helping that person get to the next goal that they have for their overall wellness. And if you don't know what to do, you're reaching out to a specialist community that's going to help you and that patient come to those conclusions. As a public health physician, I am not interested in anything that makes individuals sick. Full stop. I'm interested in anything and everything that makes them sick in groups or has the potential to, and I want you to think just for a minute about where that potential lives. It lives in municipalities and neighborhoods. And so I do have a slide. I'm hoping that the hosts can help us share it for a minute. That potential exists in our systems of justice, in our systems of transportation, in our systems of education, our systems of housing, our systems of economy. And so that's what's represented on the left-hand side of the slide, is all of those societal systems of influence that have the potential to make people sick in groups, cause outbreaks of not just communicable disease, but chronic disease and injury. if we don't manage that well. The public health system rests here. And so the way I describe that, and it's been described by others, is that the public health system is interested in primordial prevention. So you hear us talk about prevention all the time. Dr. Etches mentioned it in her opening remarks, and certainly our colleagues in the acute care system will be familiar with levels of prevention. We call them primary, tertiary, secondary, and tertiary, with primary prevention being where everybody is agreed that if risk factors for disease are out there, it would be good for us to prevent that from becoming disease. And so the healthcare system takes care of that. And then secondary prevention and tertiary prevention are, secondary prevention, the disease is established, so we didn't prevent it from happening, but we caught it early. That's our screening programs. Tertiary prevention is the disease is established. Let's help people do the best they can with it. All of that in the box on the right is what our acute care systems are focused on. Primordial prevention is about preventing the risk factors for disease from ever existing. And I just want you to settle for a moment on how big that job is. It's huge. Because as I said, those risk factors for disease come from where and how we live our lives. It's massive. And so when you start to think about that, it's hard not to get overwhelmed by the job that public health has ahead of it. But it's why public health's attachment to municipalities is so critical. Without that, we can't access those risk factors for disease. And I've had audiences say to me, Dr. Watson-Creed, come on, that sounds a little bit like public health chasing the Holy Grail. And then I've had other audiences say, oh, wait a minute, you kind of did that with tobacco. And as a matter of fact, New Zealand is taking that whole idea around tobacco a next level, right? With eliminating that risk factor for disease from ever existing in those communities. That is the type of leverage that public health can pull into conversations if they are attached to the places where those risk factors are occurring from. So maybe I'll leave it at that for now and turn it over to Dr. Lowe for some further comments.
I think Dr. Watson-Creed and I must have been reviewing the same notes prior to this panel, because I was actually going to just state it essentially as simply as you stated it, Gaynor, Dr. Watson-Creed. The reality is that lives unfold in communities. And that's where disease is developed. That's where disease occurs, especially just by virtue of the determinants that people face in their day-to-day lives. And we saw that especially in the region of Peel during the pandemic, where essentially Peel was the portal of entry for a lot of transport and goods that came in from the United States, which had very severe COVID issues in the first few waves, and subsequently had a lot of people who worked, who were very socially disadvantaged, who were working in jobs and couldn't essentially do those remotely. These were people that had to go into work, and essentially they went into work to keep the rest of us safe at home to a large degree. And so what we saw in COVID was essentially a microcosm of the essential work that public health does day in and day out in creating the conditions for good health within a community, creating the fairness and the equity that allows everyone to eventually achieve their optimal health. And I think Dr. Watson-Creed hit the nail on the head. I'm very fond of saying that the reality is that the acute care system is a lot like the legal system. You actually don't want to be involved with the acute care system if you absolutely don't have to be, right? So if you have to have some sort of medical condition that requires regular visits, tertiary prevention, et cetera, that really presents a significant barrier to your health and well-being and a significant impact to your quality of life. So public health is that essential component. It really is the first line of trying to create the healthy context in the community, first and foremost. And then now in my new role, where you're seeing this crisis in primary care with family medicine, that's also trying to keep it in the community to some extent before it ever gets to the point where it needs to be, regular visits or even hospital visits for urgent or emergent issues. It's a big job. I'll pass it back to you, President Brule.
There we go. Yes,
Okay,
great. So I think what we're looking for at the provincial level, I feel like there's opportunity, and There's also, a challenge at the moment. What's happened with the pandemic is we've narrowed our scope, and we see the pressure to continue to respond to infectious disease. Actually, it's not going away. So you've heard about the mpox, work we had to do to contain mpox in the fall and the summer. We see vaccine preventable diseases continue to form a risk as our vaccination levels and coverage has dropped. So being able to sustain some of this work and response while getting back to some of the more preventative actions that do involve work with partners. And I think that was something just to say that all of the work that was described by my colleagues of public health is absolutely done in partnership. It's not something we can do on our own. And so another thing we want to sustain and continue to have the capacity to do is that work with partners on policy, the work with partners in the community to best understand the community's needs, and certainly some of the real on-the-ground work, listening to the Black population, working alongside our Indigenous health service providers. Many in this work have been added through temporary funding with COVID, so we need to look for the sustainable, ongoing way. But I would say the opportunity I see, and maybe we can talk more about this in terms of the future vision, is that there is interest in improving how the healthcare system works. We see the need for a more coordinated, connected system. We see the provincial government's interest in this, using tools like the Ontario Health Teams. And so we're interested. We are looking for how the public health system will come alongside and assist with the focus on prevention, but in a coordinated way with the rest of the health system. So I'm happy to also pick up on that as we think into the future. Gaynor, are you able to jump in now? Yes.
Certainly, and thanks for that. So I, coming from outside of Ontario, though I did my training in public health and in family medicine actually in Ontario, and was there for 6 years before returning to the Maritimes. So I have a sense of the system there. And if I had to pass one message to the provincial government in Ontario, and also I would say to the provincial governments in Quebec and BC, quite frankly, is that here we have 3 provinces whose public health systems have been incredibly durable and sustainable over many, many decades. And I can tell you, coming from the somewhat have-not province that is Nova Scotia, we are envious of the stability that you have had in your public health systems. And it's because, if you think about the work that we've all outlined public health is required to do, that work does take a considerable amount of time. It doesn't take a lifetime, contrary to sort of popular myth. You can see public health outcomes well within a lifetime, within 5, 10, 15 years. But it does require a stability of structures and a stability of expertise in order to be able to dig into those issues at the local level and really turn things around with the help, as Dr. Etches has said, of local partners. And so my request of governments would be to not take the tinkering of public health structures as a light exercise, because it's not. And we have seen the devastating impact, I will say, of public health tinkering, I'm going to call it that, political tinkering with public health on the tail end of health system restructuring in other provinces, including here in Nova Scotia. I do not recommend it. Because when you lose that stability and public health loses its footing, it is very, very difficult to bring it back online. And, nature loves a void. And so all kinds of folks will fill in that void. The challenge is that, again, contrary to popular belief, you really do need a dedicated level of expertise in order to manage those public health issues, because they are so complex. If you think about the environments that we've described public health issues arise from, navigating that requires public health to be able to, yes, speak medicine and nursing and health promotion, but also be able to speak urban planning and architecture and engineering with those sectors too, right? It's incredibly complex. And so what we often hear, well, public health and population health is everybody's business, but that has left a taste, I think, that suggests that that means that just anybody can do it and it's nobody's responsibility. And it is the responsibility of public health units and local municipalities to dive into those social determinants, those societal systems of influence where health risk factors arise from, together in order to turn them around for communities, and stability is needed for that. So that would be the one thing that post-pandemic, I think I would be hoping for those provinces that have not yet gone down the somewhat ugly health system restructuring road.
And Dr. Loh, we'd like to hear your view on this as well.
Absolutely, and I have a few points that I'll quickly share. I wanted to build on the very important point that Vera raised around the idea of partnerships. I think there is a recognition that public health can't do this necessarily on our own. And I say our because I still identify as a public health physician, even though I've moved on to the primary care side for the moment. But really, I think what we saw through the pandemic, especially, I'm thinking about things like the vaccine rollout. I'm thinking about things like, outreach to communities, outreach to various specific communities, even in my own region where I was serving as medical officer of health through the pandemic. That demonstrated, when you fund public health, what can be done in terms of the partnerships that can actually drive health outcomes, drive effective and optimal health outcomes, and drive greater equity in these communities. Because all this funding came in, and you could see just like the extent to which we were able to reach people, for example, with this protection, with the vaccine, the extent to which we were able to engage with communities to ensure that people had access to isolation, who had access to additional supports, really spoke to, if you fund it and you fund the partnerships and these collaborations, you can really drive some very effective community outcomes. And I think that in turn, was reflected in another thing, and I always have many acute care colleagues who say, oh yeah, we should look more upstream. We should look at health in all policy. And I say, well, that is actually the raison d'etre of public health. Like that, public health is about, trying to look at policies and programs and how they impact various health outcomes. And so to that extent, I think it's really important to continue to maintain the independence of public health units from the acute care system. Ultimately, the work of public health in actually trying to shape and address contexts in the community through policy is often not the same goal that the healthcare system has. The acute care system is actually, while we do share a lot in partnership and we do share some goals in common, we don't always share a common goal, right? It's public health is actually trying to keep people out of the healthcare system in the first instance to a large degree. And so I think it's really important, having worked in other provinces where public health has been drawn into the acute care system, I see that actually really poses challenges where, they're now being pulled into hospital administration and all these other things, as opposed to their really necessary focus on creating healthy contexts in the community. And I think that also, in terms of keeping things in the community, one other really important firewall between the work of public health in shaping community contexts and the work of the acute care system in hospitals, and this is where I'm putting my new hat on, is we really need to look at how we have better supports for primary care, because primary care and family medicine, especially the way it's organized in Ontario, is really challenged by, a lack of or difficulties. We know that there's many there are many family health teams that were created, but that process never really finished. And now we're starting to see that I think the days of the solo family practitioner with a single assistant, like that's not going to cut it anymore, especially with just the complexity and the challenges that people are facing. Yet we accept that there are teams, multidisciplinary teams, that work in places like hospitals or in long-term care settings, et cetera. But for some reason, we haven't necessarily embraced multidisciplinary teams to a large extent in primary care. So I think if you're able to build that firewall with more multidisciplinary teams that allow us to work better and faster with all these different practitioners working to their appropriate scope, that also builds out a further firewall that will then also help to relieve and address any potential demand on the acute care system in the long run.
Thank you, Doctor. Perhaps a short follow-up question to this. I love your comment about we have goals in common, but not necessarily common goals between public health and primary care or acute care. And you talked about firewall, but we saw there were gaps in the care during the pandemic, and the need for coordination. You talked about your region, the Peel region, as an example, one where there were higher instances of cases, perhaps not seen in other regions, perhaps more in the east of Ontario. So there was a need to coordinate efforts. So how do we how do we conceive this in a post-pandemic world? If it's not done provincially, how do you coordinate this amongst the public health units themselves?
Well, I think there's sort of two questions maybe there in terms of coordination between public health units versus in the community level coordination between different system partners. In terms of public health units, I at least as far as I recall, there was a lot of efforts to try to coordinate to the extent possible through the Council of Medical Officers of Health and the various responses to COVID, while accounting, of course, for various community contexts. I mean, the reality is that the patterns that we saw in Ontario very much reflected the same patterns that large, federated jurisdictions saw. The large, heavily populated internationally facing and connected centers got hit first. Then subsequently, we saw it into the secondary centers, and then subsequently into rural and remote areas. And I think really to a large degree, the sacrifices of, the people that lived in urban areas who had to face significant closures and curtailments in the early pre-vaccine phases actually helped to ensure that by the time it got out to other communities, I'm thinking places like, up in the north or Haldimand, Norfolk, et cetera, by the time it actually started to transmit out into those places, you were actually able to, there was better understanding of treatments, there were vaccines available. So of course, the efforts that you were seeing out there just were, the case rates and the fatality rates that were being seen were different. But I mean, that took a coordinated effort between the cities saying, all right, we need to go, with these measures versus, and so I think there was a lot of work between public health units to actually do that. Now, I will say, in terms of coordinating among system partners, that is also an interesting role that public health comes alongside to some degree with Ontario Health and our provincial agencies. But I honestly think, in terms of primary care, there needs to be a greater understanding or support for team-based care and some sort of help, hopefully through Ontario Health teams or otherwise, that allow a little bit more coordination, because that was one of the biggest challenges we found was, just being able to quickly reach out to all the different family doctors and their practices in our region in the absence of some sort of overarching structure really posed some difficulties. But I think to the specifics of that, I would defer to Dr. Etches or Dr. Watson-Creed.
Dr. Etches on this?
I think this is really moving into our next conversation in some ways in terms of how do we go forward, right? Like what can we do so that we have a strong public health system working alongside the healthcare system that's becoming more coordinated and connected. And so I think it is about shared goals. You're right, they're sort of two overlapping circles. We have some public health goals with our municipalities, and we have some public health goals with the healthcare system. So I think it's finding those shared ones, and then I think the health system, for example, is looking to Ontario health teams to bring multiple partners together, whether they're hospitals, long-term care, community care, and they're trying to think of the idea of a clinical pathway. So imagine diabetes, for example. They're trying to create a system within the Ontario health teams where somebody can be diagnosed because they have that access to primary care that we're talking about, where they will have easy connection to the hospital if their disease is progressing and they need surgery, and if they're end of life, it's an easy, seamless, transition to long-term care or palliative care. For public health, we are also interested in diabetes in terms of preventing diabetes. And so it's about using our data. Like I said at the beginning, hospitals know who's coming through their door. We know which neighborhoods are more likely to be at risk for diabetes. And so it's adding our data together, and it's thinking about then how do we appropriately work with neighborhoods to address the things that can lead to diabetes, which are, honestly are low income, lack of access to food that is going to promote your health. That there's a role for cities in food policy and food security. And so connecting, what we see across the social service sector and the health sector, to really define that public health role and that work in the neighborhoods, and then measure. Are we making a difference? Measure, are we seeing fewer people need to actually get into the hospital for that amputation? I think these are all ways we can focus, and really have a better outcome for the whole population.
Thank you, Dr. Etches. I'll turn to Dr. Watson-Creed. So how can local governments work with a provincial government in this case to reimagine and retool that public health sector for post-pandemic?
Yeah, so I mean, you're going to hear a familiar theme probably from all three of us in some ways. I might put a slightly different take on what's been said by Dr. Lowe and Dr. Etches, in that, I would suggest that municipalities really need to focus on keeping that strong tie to those social determinants of health that live in communities. That's just a given for public health practice. And so the way I describe it to my acute care colleagues who regularly ask me, what is it public health does exactly? Including my own sister, who's also a family physician and is the reason I got into public health, and then looks at me and says, I have really no idea what you do outside of pandemics. But what I say to them is, we all know as clinicians, yeah, I mean, they're still happy that I do it, but they really have no idea what I do. But what I say to them is, we all know as clinicians the right thing to tell our patients in order to stay healthy, and it's usually a variation of eat well and exercise. But what I say to my acute care colleagues is, if our patients leave our clinic spaces and they go out into community and they can't do those things because it physically does not exist in their communities, there is no point to us saying those things in our clinical spaces. And then they say to me, well, how do we make it exist? I'm like, well, that is the job of public health, working with municipalities, right? And so that's something that I would say municipalities need to hang on to going forward, because nobody else is doing that work. And so in navigating sort of the next round of conversations with provincial government in Ontario, I would say, in addition to that, there is a right size for that is pointed to in the literature. The right size for that is between 500,000 and 1 million population. That's the sweet spot of public health resources, municipal engagement, and impact. And there is good evidence from both the US and the UK suggesting that that's what we need to hang on to. And so with that in mind, the coordination that Dr. Lowe and Dr. Etches have both spoken to is also really important, but I would want to be careful not to replace the idea of coordination with the idea of control. Those municipalities in Ontario are necessarily distinct. They are different communities. And so you can't treat them as though they're one, because you will miss the opportunity for local intervention where it really counts, because in this community, there's a particular thing that's happening that's not happening anywhere else. Just to give you a small example from the city of Halifax, which is about 450,000 people. And I had the pleasure of being part of an injury prevention workshop that we were hosting with a number of stakeholders, our fire department, our police department, our local Red Cross, all the rest of it. Everybody was concerned that the issue was violent crime on the Halifax Peninsula, in particular in the Halifax Common. This was about 10 years ago. And when public health brought the data, to Dr. Etch's point, what we realized was that where people were dying the most was in our rural communities, and who was dying was women over the age of 80 who were getting in their cars and driving because those rural communities were not built to support them as they aged. And so the intervention is not in the healthcare system. The intervention is with the local community planners in those rural areas to figure out how we actually build these communities for seniors so that they don't have to get in their car and drive 30 minutes to Halifax to get groceries, to do banking, all the rest of it. That's the type of work that public health can do if it's well situated in those municipal relationships. And so coordination is important, but that issue that was happening in rural Halifax wasn't happening in Cape Breton in the same way, right? And so we'd make a mistake to think that at the provincial level, we can have a blanket policy around this that covers every municipality and every eventuality, because they're distinct communities that need that distinct level of focus and surveillance data for diagnosis, as Dr. Etches started with.
Really great example, Dr. Watson-Creed. It takes it home. I think everybody can relate to this and understand that, yes, we need coordination, but we don't want control, because really we need to be able to affect change and really promote prevention at the local level. So really well said. Thank you very much. Now, we have, as I said at the beginning, we have a Q&A. We'd like to be able to have our audience ask questions, either our live audience here today or people who are at a distance on Zoom. So feel free, if you have a questions to our three panelists, type it up in the Q&A, and I will pick up your question as we go. And we see a hand up here in the audience, 2 hands up. All right, so we'll go over to our live audience who can ask their question.
Hi, my name's Peter. I'm a principal at Santa's Health, and I live 5 minutes from here, so thank you for hosting something close to my house. I have a hard time trying to ask this question. I've been thinking about it because Dr. Wilson-Creed, you've said a couple things, and you've all had, there's this undercurrent of the discussion of we have to keep public health independent, we need to coordinate a little bit more. So it leads me to believe that you're alluding to something about when we're looking at system change, that there might be a fear of public health of if the rest of the system is changing, what does this mean for us? And the reality in the healthcare system is that you're competing with a set of priorities predominantly set by provincial governments. And when we're facing, acute care challenges to the extent that they are, and they cost so much more, so often that takes the attention of governments, and public health is often left to the side. And you see recommendations from Dr. Naylor's report after SARS, you've seen recommendations in the past. Dr. Wilson-Creed, you said outside of the pandemic, my sister doesn't know what we do. So how do you start thinking about articulating the benefit of public health to a population in a way that provincial governments respond in kind in terms of funding and support, especially when you start thinking about what are the top 3 priorities for public health outside of a pandemic, rather than a long list of social determinants of health, which although everybody would agree with, you can't tackle all those at the same time because you'd be boiling the ocean. So how do you start encapsulating here are the 3 things that we're doing outside of a pandemic that justifies a priority of resources against other priorities in the healthcare sector that consume most of provincial government's attention?
I'm happy to start, if that's okay, President Brulé. I think it's an excellent question. And I see that your mic is,
Yeah, my mic is back on. Go ahead, Dr. Watson-Creed.
Yeah, I think it's an excellent question. And I think it's an age-old conundrum in public health. So here's what I would offer. And I'm curious to know what Dr. Etches and Dr. Lowe think. But I would start by acknowledging that absolutely this is the conundrum. We call it the prevention paradox in public health because part of what happens, our colleague Dr. Eileen DeVille at Toronto Public Health has said this regularly, when good public health is happening, then nothing is happening. So how do you get people's attention with that, right? It really is a paradoxical position to be in. Having said that, I think the question around public health prioritization, and I've been at some of the national tables where these conversations happen, and I'm always a little frustrated by that conversation because I think it undermines the whole point of the public health structure, which is to rely on that surveillance data at the local level to tell us what the priorities are. And so I would say that it's less about naming which top chronic diseases, injuries, communicable diseases are priority, because they'll shift from community to community, and more about naming what structures and processes are a priority for development in the Canadian public health system. And there I would say surveillance systems that get at that local data certainly would be a top of the list for me. The challenge is that it is not that different than the conversation actually that's happening in healthcare now, right? We're not having a conversation about primary care to deal with chronic disease necessarily, or to deal with addictions or anything else. We're having a conversation about the structure and function of the primary care system. That's really what has political attention right now. And so I would say a similar conversation is not out of place in the public health system. Having said that, what's interesting about the positioning of public health and all of that is that my read on the Canada Health Act, and I've been at several national conversations about this during and since the pandemic, is that it doesn't directly speak to public health the way it speaks to acute care services. And so the provinces and territories have a mandate through the Canada Health Act to deliver on acute care services that sees them give that a political attention because they know that they're on the hook for it. That same sort of responsibility for public health is not clearly articulated in the Canada Health Act. And so I think there is a solution in adding public health into that federal provincial framework in such a way that it's front and center for the provinces. They actually need to know that this is a requirement and they need to pay attention to funding it, and also paying attention to what structurally does that mean they have to make sure is in place for every local municipality across the country.
Thank you very much for that question. and for covering the answer, unless there's another comeback here.
I might just add, I think concretely, people do need to understand what are you going to change in health. And I have two board members here, I think, as well. Online, I believe Councillor Kavanagh and Member Tilley here in the room. Our board helps by, again, local connections, listening to the community, identifying along with our data, what are the top needs we need to focus on now. And so specifically, our strategy right now is saying we need to look at mental health and substance use specifically, and then we need to define, what we're trying to do is keep people, build their resiliency, prevent suicide, very specific things that we're looking at with partners always. And then we are concerned about immunization on an ongoing way. That's during pandemic, between pandemics. And so again, very specifically, what do we need? We need better databases, better like an immunization registry. You saw when flu came around, people were like, well, how many people have their flu shot and where? And well, we can't tell you. Like you could for COVID, the systems don't exist. As Gaynor was saying, we have to strengthen our data systems. That's a specific ask, a specific priority. And I think also on our list, as our board is thinking through our next strategy, is supporting early childhood. And this is where you can actually see a difference in 5 years, right? It's not like trying to prevent cancer in 20 years. You can intervene and support childhood development today, and you will see children start school successfully in 5 years. And so these are things, we can measure then. We could measure readiness for school. I think that we do need to do a bit more of that in the public health sector, is to actually look at how we tell that story and measure our impact. Thank you for.
President Brule, if I could quickly weigh in just to add a very small point. A lot of public health units actually have strategic plans that are released and available to the public, and that is based on the core aspect of public health planning, which is population health assessment, knowing the community that you're serving. And I can still remember even in Peel, I could probably recite the strategic priorities off the top of my head. It was about promoting health equity. It was about mental health and well-being. And so, yeah, there is an opportunity, I think, for different communities to set different priorities. And I think as an engaged citizen, it would behoove anyone to know what your public health unit is working on and potentially, working in partnership with them. I will add that local focus has actually driven a lot of really effective health policies to the extent that obviously during COVID, we were able to see, suppression of the disease in the large metropolitan areas first before it started, really slowing its trickle out. But even things like tobacco, which Dr. Watson Creek started out with, that ultimately started in places like the city of Ottawa and the city of Toronto and Ontario with local action. As that became a priority and a bigger focus for different public health units, eventually you had enough local public health units that came in such that the Smoke Free Ontario Act was something that could then be a next logical step taken by the provincial government.
Thank you very much for your additional comments, Dr. Etches, Dr. Loh. We're very close to the end of our time together. I know some people had put questions in the Q&A. I think you've kind of addressed a little bit of it in terms of what would be your specific ask for the provincial government. So thank you for adding that component. And one comment that was made, we talked about tobacco. Of late, there's also the issue of alcohol consumptions and the side effects of that, and what perhaps public health role could be in that arena. And I see that Dr. Loh and Dr. Watson-Creed are typing some answers to that question online. So thank you very much for those comments. So one time for one more question from Dr. Beck, and then we'll bring this to a close.
Thank you very much. Just wanted to say it's very nice to see Dr. Loh again. I haven't seen him in person in a number of years. I want to thank all of you, and I want to thank you in particular for your courage during the pandemic and even after. As someone who watches on Twitter, I thought it was shocking in many ways the way public health professionals in Canada were treated. And so my question is related to that. What impact has social media had and will have on public health in the future and on the actions that are really necessary? Do you think it diverts us away from good public health?
All right, who would like to start on this one?
I'll quickly say, I think that it's highlighted the challenges with misinformation. So it's probably calling us to greater action on the front of combating misinformation. And here we are in a college, right? So again, this is not something we can do on our own. This is something educational institutions probably have a fundamental role to work on from a very young age through adulthood. And I think for me personally, it is calling us to do that work to overcome divisions in communities locally, and to call us to do the face-to-face work of building understanding and common priorities in neighborhoods on the ground. Because in a digital space where people are commenting from other countries, that's not going to build common ground. And so I think to counter that with public health action locally is one thing that I'm focusing on.
Dr. Lowe, do you want to comment on that?
I'm happy to comment, and I really appreciate the question. I think I've been very concerned about the divisiveness that I think social media has portended. One of the things that we understand, as public health practitioners, as family doctors, et cetera, is that nobody is an island, right? I think we're all, if anything, the pandemic showed us that we're all ultimately connected. And I think it's now more than ever, we actually need to be coming together to find solutions to take care of those that are more vulnerable in our society, to try to figure out how we move forward together. And I've really, I think the challenge with social media that I've seen is that many people have started to fall into various camps or certain perspectives without realizing that, first of all, there is a role for public health and for public health agencies to try to offer recommendations and advice, under their legislative mandate, to the best of their ability to serve the community and respecting the data and evidence that's before them. And I think the second thing is that it really is about everyone bringing their different viewpoints together to try to find some common ground, since we ultimately do need to share the community context together. I wish social media could actually do more of the latter rather than what it seems to be doing nowadays.
Last word to you, Dr. Watson-Creed.
Sure. Years ago, we sent our communications consultant from the health unit in Halifax, when I was the medical officer there, to a communications conference that was co-hosted by CDC Atlanta and Coca-Cola, who are across the street from each other in Atlanta, if you know that area. And she came back with this really sobering realization that in the age of social media, everybody can be a journalist. And so those ethical principles of journalism that we rely on from our mainstream news broadcasters, if we're lucky, don't necessarily exist in those who are reporting on events through social media. And it was a really good reminder for us at the time about how cautious we need to be in that space. Social media has done a world of good for public health as well, I would say, in many ways, when public health can participate constructively in those conversations. But I would agree with Dr. Etches and Dr. Lowe around the divisiveness that's there and the lack of ethic that is often part of sort of what gets shared there. And so I think going forward, there's a way in which we need to get savvier about how we engage with that, how we use inoculation strategies from communications to combat misinformation, all of those types of pieces, and there's good evidence for those. But it's not a surprise that the World Economic Forum, I think, has labeled this sort of rise of misinformation as one of the key challenges of this century, right? So it's not going away anytime soon.
Definitely not. Thank you very much for your answers. Thank you, Dr. Beck, for that question. It's a big question. It touches on not only public health, but all segments of our lives. So I want to thank Dr. Etches, Dr. Watson-Creed, and Dr. Lowe for participating. Thank you for your time. Thank you for sharing your insights. It's been wonderful to have you with us this morning. You're giving us a lot to think about the future of public health, certainly in a post-pandemic world where we all need to work in a coordinated fashion, not a controlling one, to achieve goals that we have in common, even though we may not have common goals. So thank you very much for your time this morning. And thank you to our audience for being such a great audience. And this concludes our event. And we thank you. Miigwech. Merci.